All right, hello everybody. So it's extra special to be here today. I actually went to LSU Medical School, but my first year was at Pennington Medical School. And we actually have a t-shirt that was made because after Hurricane Katrina, we moved our medical school and we actually had classes in this auditorium for an entire year. I think I sat like right around where Amanda's sitting. And so it's really, really special to be up here talking to you guys. And then fast forward, I also met Dr. Kaczmarzyk through the report cards. I would go as a medical student, then as a resident, and that's really what sort of gave me the vision of what I wanted to do as a pediatrician and now as a pediatric obesity specialist. So thank you, Amanda, for suggesting that I speak today, and thank you guys for having me. So let's get started. This is my family, and we live in Covington. I'm born and raised in Louisiana, and I just wanted to pinpoint that I do this for the kids, my kids, and the kids of Louisiana. And so I am representing Our Lady of the Lake Children's Health as well. Proud to say that we just had our 1-year anniversary of the Pediatric Weight and Nutrition Center. So all of my team members are actually here, which makes me really proud. Raise your hand. I've got our dietitians, I've got our social workers, our pediatricians, and we have been open for 1 year taking care of patients on the 4th floor of the Children's Hospital right here in Baton Rouge. And this was our 1-year ribbon cutting, which we cut a measuring tape. So, and you see my mom there. She wishes she could be here today, but I actually didn't invite her. She's watching the kids. All right, so let me tell you a little bit about our clinic. So our clinic, and this is based on that stage 3-4 treatment. You remember Dr. Cook, I think he showed the different stages of treatment, starting with stage 1 right there in the pediatrician's office. I do act as a pediatrician in Bogalusa, Louisiana, 2 days a week, and so I do the stage 1 and 2 treatment over there. But then on Fridays, I come over and do the stage 3 and 4 treatment as a specialist. And so what we have is we have medical providers who are trained in weight management, myself and Dr. Holland. We have registered dietitians who see our patients, and they're sitting right here in front. And we've got a behavioral health coach, and we do food and activity monitoring and goal setting. And I think this was really, really important that we don't just teach nutrition and tell them to be active. We do a lot of behavioral techniques. We give them tracking sheets. We make goals with them every visit to try to help change their behaviors as a family. And it's a family program. We work with the entire family. It's focused on the child, but we invite the entire family. And we have visits every 2 to 4 weeks. So this is true stage 3-4 treatment. We have seen patients from all over Louisiana, and a couple in North Louisiana have driven, which always surprises me when they tell me they drove 4 hours to see us. And we also offer virtual visits. So I live in Covington, and so on some Fridays I do virtual visits, and that can be for a child anywhere in the state of Louisiana. And we know that in just 1 year, we've had over 500 referrals, and that's only with advertising in Baton Rouge area. We have only been able to see 100 patients because right now it's only 1 day a week, and we always have at least 100 or more patients on our wait list. Now imagine how many patients don't even know about us. We'll get to the numbers later. So we looked back over the past year. Of those 100 patients that we have taken care of, the average BMI was 35.7. And you guys are probably familiar with BMI, as we've talked about. So we know for adults, BMI 30 and above is considered obesity, right? Well, for kids, we use the 95th percentile, which we also talked about. Well, when you get above the 99th percentile, then we start using percentiles of percentiles, which I always find kind of confusing. But you don't have to know all this, but all you have to know is that we are taking care of the patients with the most severe obesity in our state. And my take-home message today for you guys is that obesity is a chronic, often relapsing disease, and we need to be able to treat it medically, okay? So I'm hoping that you will walk away, everybody will walk away feeling that way. Because I know some of you probably still feel a little bit uncomfortable with that idea. Like, is it really a chronic condition that needs to be treated with medication, with surgery? Or should we really be putting, a 15-year-old into an operating room and taking out part of their stomach? You know what I mean? So everybody still has a little discomfort with this. Should we really be prescribing obesity medicine to kids? So let's talk about it. Is it really a disease? Chronic disease. So what is a chronic disease? The CDC defines this, a condition that lasts 1 year or more and requires ongoing medical attention and or limits activities of daily living. Okay, pretty simple. They lay it out. So let's ask ourselves, diabetes. Is diabetes meeting these three? Would everybody agree? Yes, it usually lasts more than a year once you have it. It requires medical attention and limits activities of daily living. So should we treat diabetes, especially pediatric diabetes? Of course. Everybody would shake their head. Yeah, of course we should. Now, what if a patient comes in my office and says, you know, and this actually happened 2 weeks ago, we haven't been checking our sugars. We have sort of not been following the diet plan. And I checked the sugar in the office literally 2 weeks ago, and it was like 400. And so does that mean then that because that family is not able to follow the treatment plan, and because maybe their personal choices and behaviors are not fitting with the plan, does that mean I shouldn't treat that child? Does that mean I shouldn't give them the insulin and the treatment that they need? I'm hoping you're thinking no. Okay, so same thing with hypertension. Again, it's a condition that lasts more than a year. It requires ongoing medical attention. It limits activities of daily living. And if I have a child who comes in with a really high blood pressure, and I see in their backpack they've got some Takis, which is really common, and they're drinking a Diet Coke, should I not treat their blood pressure? Should I then say, well, no, you have to get on a better diet until I'm going to give you this blood pressure medicine? No, right? Everybody agrees that. So the same is with obesity. Obesity is a condition that typically lasts more than a year, requires ongoing medical attention, and definitely limits activities of daily living. So if I have a patient who is walking in with a donut, which doesn't happen that much, but if they are maybe having some personal choices or behavior choices, they're not very active, that should not change how I treat that child in that family. So I ask you, should a patient's personal choice and behavior change the way that we as healthcare providers medically treat their disease? I hope everybody gets the point. And why? Because it's so complicated. When I was studying for my obesity board exam, oh my gosh, it was harder than pediatrics for sure. It was so complicated, and all the different hormones. I don't know if you realize how the brain and the stomach and the gut all interact through a million different neurochemicals. And I see Dr. Hauser over here, who's board certified as well. She's shaking her head. It's so complicated, and it truly is a biological disease. And what happens is once you get enough fat accumulate in the body to call it obesity, that fat not only displaces healthy cells, everybody's heard of fatty liver disease, that fat pushes the healthy liver cells out of the way, but did you know that that fat actually starts to secrete hormones? And those hormones disrupt this balance, and then all of a sudden, your hunger, your satiety, feeling full, and your cravings are all sort of out of balance. And so I ask you, which comes first? Is it the hunger, cravings, and poor satiety? Or is it the unhealthy behaviors? Is it the chicken or the egg? And in my opinion, after studying this topic, it's the hunger and cravings and poor satiety that often drive the choices that the family and the child is making. And there is some reciprocal interaction, but that's what I want you guys to walk away realizing, that why is that family choosing that unhealthy food? It may be because their hunger signals are not regulated. So when we see a patient in the clinic, there's the iceberg that you guys saw earlier with Dr. Inelli. We are just seeing the tip of the iceberg. We are just seeing a little bit of that family's life. And under the surface, there are, like we said, social determinants of health. There may be mental health. There may be a million other stressors that that family is dealing with every day that's affecting their personal choices and behaviors. And so it's our job to just look at the health and the medical obesity and treat it like it should be treated. So if we don't treat obesity as a disease, we can put a trajectory. We're going to have to treat all these other diseases. And obesity has been linked to 100 different diseases, including cancer. And so that means that we're going to have to pay for the medical treatment of all those diseases. And so what is it? It makes more sense, right, to just get right to the middle, get right to the obesity that causes all of the other diseases. So, should we treat pediatric obesity as a chronic disease? Yes, thank you. Okay. And so, what is the treatment? Dr. Cook showed this in 2007. They came out with the guidelines. Every pediatrician has access to this. Every doctor has access to this. There are studies showing how do we treat it. We're about to get the new guidelines. I'm excited to see. So again, there's that stage 1 and 2 treatment. There's stage 3 and 4 treatment. I'm going to talk about 3 patients that I have been seeing for stage 3 and 4 treatment. Before I do that, I just want to show you just sort of an overview of what is treatment look like. What does it look like if you are a child with obesity getting treatment? So at the foundation is behavior and lifestyle. We've talked about that. The intensive behavioral therapy, that is the gold standard, but that behavioral and lifestyle treatment could be in a community setting with our dietitians. I've seen some dietitians speak up. It could be in a school. And then next step would be pharmacotherapy, which means medications. And then above that, you've got bariatric surgery. So how do we decide who gets what? Well, there's some guidelines on this. So if your BMI is 25 or above, which is technically overweight, or your BMI, if you're a child, is 85th percentile, you qualify for that behavior and lifestyle treatment. If your BMI goes to 30 or above, or 95th percentile, or 27 with a comorbidity, you can qualify for medication. And I think this is really fascinating, is if you think about the number of kids with a BMI of 30 and above, that's a lot of kids who are not getting the medication they deserve. I think the statistic is 1 percentile or less of patients with obesity are offered medication. And then you've got BMI 40 and higher who qualify for bariatric surgery, which would be the 140th percentile of the 95th. So what are the effects of each type of treatment? So if you do some behavioral and lifestyle treatment and you do it really, really well, on average, and this is not super scientific, this is on average, Dr. Stano can probably tell you better numbers, it's about 3 to 5% BMI change, which is good. It helps with some insulin sensitivity, a lot of different, maybe my foot was hurting, now it's not hurting, I feel better about myself, I feel better in my clothes, lots of health effects from that. I'm not gonna diminish that in any way. But sometimes a child who has a true disease of obesity has other things going on. Prediabetes, they often have high cholesterol, they often have high blood pressure, often have fatty liver disease, sleep apnea, PCOS, which is polycystic ovaries, asthma exacerbations. And we know that usually in order to affect those things, we need about 5% weight loss. Now, if it was a really motivated family, you might get that 5% with your lifestyle change. But if they're not quite following everything because they have a lot of other things going on in their life, we may need to do more to help them. And so that would mean providing pharmacotherapy, which can give 5 to 10% weight loss. In addition to that 3 to 5%, so that's pretty good. It is additive. And then there are some cases where even that's not enough. Sometimes we have type 2 diabetes. Sometimes we actually have NASH, which is when the liver actually starts to have true disease from the fat. And then, and GERD, which actually I needed to change that slide. I'm not sure that's quite accurate. I got this from a friend of mine. So 10 to 30th percentile is what surgery can do. 10 to 30% weight reduction in BMI. All right, so y'all are gonna see this slide a couple of times. As we go up in the treatment, obviously it's more expensive. Okay? So what does that foundation look like? Behavior and lifestyle treatment. What it looks like in our clinic is our patients meeting with our dietitians and our social workers and our providers, talking about all the different topics that we know are good, healthy topics to talk about, right? So we kind of know this. And this is all guided by guidelines in the American Academy of Pediatrics, et cetera. And we know we've talked about the dose. Y'all made my job easier because a lot of people talked about this. 26 visits within 12 months is shown to be effective. Now, in our clinic, we can't always get 26 visits in a year, but we try. We try to offer visits every 2 to 4 weeks. But I'm really, really happy to see the speakers who are following me because we need more of this lifestyle treatment to be done in the community. We need more community programs, after school programs, in the YMCA, in the schools. We need more to be done because us as medical providers, we really can't provide those 26 visits. So maybe we provide 10 and you provide 16, something like that, okay? So that's why I'm really excited that we are here partnering on this. And so let's talk a little bit about pharmacotherapy. So there are 4 currently FDA-approved medications for obesity in adolescents. There's 10 for adults. It's not really fair, but there's 4 for obesity. The first one is orlistat. You may have heard this. This is over the counter. You can go pick it up right now at the Walgreens. But it causes a lot of GI upset. Almost, I don't know really anyone who's using it. Second one is called liraglutide. It's actually a little tiny injection they put in their stomach once a day, and it actually reduces hunger in the brain, and it helps improve satiety. It works on the GLP-1 receptor, and it gets super complicated how it works. It's also used for diabetes. I love this medicine. I see sometimes 10% weight loss from this medicine. Problem is, it's over $1,000. I don't know of any insurances that cover it for obesity, especially not Medicaid, and so it's hard to get for a patient. Third medicine, I'm super excited to say, is a new oral medication called Qsymia, which is a combination of phentermine. You may have heard about phentermine for adults. Well, now it's approved for 12 and up, combined with topiramate. You may have heard of that drug before, which is used for migraines and seizures. They combined it, and they realized that this can lead to an average of 7% weight loss, and it's shown to be safe and effective. A lot cheaper. So now it's an oral medicine. My teenager doesn't have to do an injection, and now they can get it about $100 a month. But there's a lot of families that still can't even afford $100 a month. It also is not covered by any insurance that I know of in Louisiana. And then you've got phentermine for 17 years and up, and that's only approved for short-term use. So they can take it for 90 days, and then you have to take them off of it. Which makes no sense because obesity is a chronic disease, right? But that's what it is right now, approved. So, coverage, it takes us a lot of time in our clinic to cover, really to go into details about the prior auths. I know when I prescribe something, automatically I know it's gonna be denied, but we go through the steps anyway, and then we do the appeal, and then we do the appeal to the appeal, then we do the peer-to-peer, and I spend half my days off working on all this stuff. And so, thankfully, we have what's called a 340B program. So our hospital gets sort of discounts on medications, Children's Hospital Baton Rouge. And so because I'm a hospital clinic, I can get that shot. I told you that's $1,000 for $4. It's awesome, but you have to have Medicaid. So then it leaves our private patients without any treatment. So you see how hard it is. It's like I'm trying to do medicine, but I don't have access to the medicine. And then bariatric surgery is the very last part. It's interesting because bariatric surgery is approved by Medicaid for 12 and up. So we have the most expensive treatment covered, but we don't have all the other stuff covered. And bariatric surgery, there's definitely a place for it. We are working with Metamore, is the bariatric surgery, to try to develop an adolescent bariatric surgery program, and there is a place for that. But it's interesting that the access is better for that than for the other stuff. So let's talk about some real patient stories real quick. So when all goes well, let's talk about a success story. I have a 16-year-old female comes into the clinic. This is true real life. And her BMI was 41. Her percentile was 143rd percentile. So she was in that most severe class of obesity. She presented to me already having signs of polycystic ovary syndrome, which means her periods were irregular. She had hair growing on her upper lip. She had prediabetes. She had anxiety and depression. She had been hospitalized for suicidal ideation, I think the week before I saw her. She had fatty liver disease. And so this is her growth chart. And you can see when I saw her, it was about right there. She was just going up and up and up. She had been to like 3 or 4 specialists. She'd been to her pediatrician. Nobody was able to help her. And the family's like, I don't understand, why is my child's weight going up and up and up? So what do we do for her? So we know that she did qualify for bariatric surgery. However, the family was not ready for that. And most of her comorbidities really were in the range of if I could just give her a medication and do lifestyle therapy, then I would probably be able to make some changes. And so that's what we did. We prescribed her liraglutide through that 340B program, which was great. She had Medicaid. We did metformin, monthly visits, changed her psychiatric medicine, which, by the way, was part of the reason she was gaining so much weight, because her psychiatric medicine was causing it. And we did some behavioral health treatment and lifestyle change. And did it work? Yeah, it worked. Take a look at that. I mean, she is doing great. In fact, almost every one of her comorbidity has changed. Her BMI has gone down 18%. Her comorbidities have pretty much almost all resolved. I have nothing really to talk to her about anymore other than you're doing great, and she wants to keep on the medicine, and her quality of life has improved. So that's when all goes well. That's when I can get the medicine. That's when we can do the therapy the way it should be done. Now let's talk about when there are barriers to access. So I've got another patient. She's 13 years old. She comes in. Her BMI is 66. She's probably one of the most severe that I've ever seen. BMI was 253rd percentile of the 95th. She did have Down syndrome. She had prediabetes, Blount's disease, which is when there's so much weight that the calves, the tibia just kind of start, and it affects the growth. And then she had sleep apnea, fatty liver disease. She had to have a liver biopsy before she saw me, high blood pressure, you name it, she had it. You couldn't even chart her BMI, okay? This is actually the extended BMI chart, and she still couldn't be on the chart. This is her, and her mom let me share this with you guys today. And she's awesome. She's full of joy. She likes to be active. If you ask her every question, and my staff knows this, they're doing everything. They're checking the boxes. They're feeding her healthy snacks, and they're not giving her sugar-sweetened beverages, and they don't give her much screen time, and she's very active. She's doing everything. But it wasn't working. Why? Because she had a disease of obesity where the signaling and the metabolism was not working. So how did we help her? Well, I told the mom she qualified for bariatric surgery. She was not ready to hear that, and we continued to sort of plant that seed. But we decided to start with the pharmacotherapy and behavioral and lifestyle change. And so her treatment course, she couldn't tolerate the metformin for her prediabetes, unfortunately, which was fine, but she was having a lot of upset stomach from that. Her insurance was a private, I won't say which one, private payer, would not cover those injections. At the time that I first met her, we didn't have that Qsymia available. And so I really had no medicine to give her. The mom was actually like, I'll pay $1,000 a month. And I was like, no, she's a social worker. I'm like, just hold on. We're about to get approval on another medicine. And she held on. And we'd have had her going to multiple specialist visits. She even had a personal trainer that she sees, I think, once or twice a week. She was doing everything she could do. So did it work? BMI only went down 0.2 kilograms. So here we are. I told you 3 to 5% with lifestyle. It just wasn't working. Why? Because her disease was stronger than what we could do for her. And so comorbidity stayed the same. In fact, she's getting a sleep study at the hospital tonight, so she couldn't be here. But her health and quality of life, even that little bitty drop in BMI, has made a difference. And her goal was to be able to walk at Disney World without a wheelchair. And she was, I'm proud to say, able to walk at Disney World without a wheelchair. And that makes it all worth it. So this is her. She did. She was on like a fundraising, Dancing with the Stars sort of thing. And so she's a ball of energy. But really speaks to a family who has resources, but because their insurance doesn't cover treatment, she was unable to get it. And I'm going to finish with one last story. So this is, what if we do all that and then they still keep gaining weight and the treatment doesn't seem to be working? This is a patient I see in Bogalusa. This is actually the very first patient that I prescribed medication to. I was just newly board certified, and so this patient is very special to me. He is a 12-year-old male with severe obesity. His BMI is 56. BMI percentile, 238th percentile of the 95th. Again, you can't even see it on the chart. He had the prediabetes. He had the Blount's disease. In fact, he's due to get surgery soon on his knee because it's bulging out from the bone. Sleep apnea. He doesn't like his CPAP, he doesn't wear it. He has high blood pressure and asthma. So same thing, I told mom he would qualify for bariatric surgery if she wanted it. She said, let's try the medicine first. I said, great, let's try the medicine first. So we put him on metformin for his prediabetes. We put him on liraglutide, that's that shot that he had Medicaid, so I could get the 340B pricing. And even though Medicaid didn't cover it, I could do that because I was in Bogalusa, had it at the hospital. We did lifestyle changes. We referred him to bariatric surgery, sort of as an education. Mom wanted to learn more about it sort of thing, and refer him to orthopedic surgery. Now, initially, he lost, and I don't have his initial chart because I couldn't zoom in, but he did lose about 5% of his BMI with this initial plan. But then, it just started to go back up. And now, looking back over a year time I've been taking care of him, his BMI has actually gone up, 0.2 of his actual BMI. His comorbidities have gotten worse. He's having to have another sleep study, and just his general health and quality of life. So I'm like, what am I doing wrong? This is not working. Why? So what we did is we did a saliva test. We actually have these free tests available where we can swab their mouth. We send it off, it's free, and this company tells us, is there something we're missing? And sure enough, he had 6 genetic mutations that can affect the signaling between the brain and the gut. How many kids and people are out there that have these mutations we don't even know about, right? And what's interesting is that he had one that was called BBS12 mutation. And what BBS stands for is Bardet-Biedl syndrome. And Bardet-Biedl syndrome is specifically working this little spot right there on this POMC neuron in the brain, that affects the way that leptin gets carried, You don't have to know all this details. All you have to know is that leads to hyperphagia. Hyperphagia means hungry, hungry, hungry. This mom has 5 kids. He's the only one that sneaks food, the only one that goes in the fridge at night trying to find the food, and his drive to eat is super high. And so this Bardet-Biedl syndrome, can we do anything about it? Yes. As of a couple months ago, they approved a medication to treat it. And this medication is called Imcivree. I just wanted you to know about it. It's called setmelanotide generic. It works directly on that MC4R, helps reduce hunger, hyperphagia, improves satiety. Do y'all think it's covered? No, it's like, I don't know, it's like a couple $1,000s. It's not covered. In fact, Dr. Gordon, I need to speak with you because they have your insurance plan. And so it's been denied. I actually didn't turn in the right paperwork, so I had to read prior auth, then it was denied, then I did a peer-to-peer, they denied it. And so here I am trying to help this kid who has a disease and a genetic cause of the disease, and I can't do anything about it. Y'all see my frustration? All right, so that's setmelanotide. It's also approved for 3 other genetic defects. These 3 are all, you have to be homozygous, but for Bardet-Biedl, you don't have to have the double mutation, you just have to have the syndrome. So what are our next steps? We'll keep working with the families. We'll keep taking steps little by little. I actually met with the head of Medicaid last week to try to get them to get anti-obesity medicine on their formulary, and they actually gave me some support and said we're gonna do that. But we need Ms. Pat Moore to help with some policy. We need everyone in this room to do something. Our clinic, our future direction is we want to have more providers. We want to help, we want to do an adolescent bariatric surgery program. We want a psychologist. If there's a psychologist in this room, come see me, or someone who can do behavioral therapy. And we want to do a disordered eating clinic. We see a lot of binge eating disorder, bulimia, things like that. And we want to have, of course, a full-time staff, not just 1 day a week, and some satellite clinics. We are working on some advocacy. We have a grant to try to improve access to healthy food in East Baton Rouge Parish. We have an obesity task force. We are doing things with the Louisiana Obesity and Diabetes Collaborative. We're trying to do it, but we need everyone in this room because I'm here with the patient, sort of like feeling like these patients just keep coming and I just don't know how to treat them. I don't have the stuff I need to treat them. And so I sort of see it as like at the top is where we can, the prevention and the policy and the bigger picture is like where we can hopefully prevent this big stream of patients. So we can treat the obesity But wouldn't it be better if we just prevent the obesity? And so how many children are we talking about in Louisiana? Well, I looked it up. There's about 4.6 million people in Louisiana, according to the 2020 census. And about 23% of those are under 18 years old. So we've got about 1 million kids in Louisiana. So about 20% of those kids, average, have obesity. So they already have the disease of obesity. So that means about 200,000 kids in Louisiana need our treatment. Need treatment. It's overwhelming to think about. So I need all of you. Hopefully, everyone in this room will walk away with at least one thing they can do. Policymakers, public health officials, healthcare providers, businesses, the patients, we need them to tell us what they want, and we need the schools. And these are some of the partnerships we've already made. We went to the legislator and did a Louisiana Childhood Obesity Day. That's where I met Pat Moore, and so that we'll continue to do things. And we have a fun, healthy alphabet series. This is September is Childhood Obesity Awareness Month. If you didn't know, you can go online and check out our fun videos. Some of the people in this room have done videos where we did like A is for apple, B is for breakfast, C is for checkup. You can scan the QR code, or you can go to the website. But it just was really a way to bring partners together on this topic. Today is our very first Louisiana Obesity Society meeting. It's going to be right outside, I think, in the upper floor. And the idea of this is anybody who is taking care of patients with obesity, it could be a physician, it could be a mid-level provider, a dietitian, a behavioral health worker. If you're taking care of patients with obesity, pediatric or adult, then you're welcome to come. We're going to have some networking and explain to you our vision. So start where you are, use what you have, do what you can. You don't have to be perfect. And these are my references. Gratitude to my team that are here, gratitude to my family, and of course, God. And this is my information. So if y'all have questions, happy to answer. Please reach out to me, email me. This is our website if you want to learn more about referral to our clinic. Thank you so much for having me today.